Welcome back, Health Impact audience. We're in our second day now of Health Impact Spring, and we've had a lot of discussions about the tactical, operational kinds of things that hybrid healthcare brings in. But now we wanted to really kind of peel the onion back a little bit and maybe think about it from a bigger perspective, which is, what does a real comprehensive digital strategy look like for this new hybrid world? And for that, we've got a very good panel, specifically because we're talking both to the payer side as well as large systems, both in the Northeast as well as in the Northwest. So we've got a lot covered here. I'm going to have our panelists, as usual, introduce themselves real quick. But before we do that, I wanted to talk about what we're going to run through over the next 45 minutes or so. Just remember, you've got 30 minutes with the panelists, and then of course, they'll come on live to answer questions. So please get your questions ready and go ahead in the chat and ask any questions if you'd like as well. So our big question is, what's working and what's not? And we're going to talk a little bit about where that evidence is versus where it's all mostly opinionated. And there's a lot there that is opinionated still, but we're starting now after about 14, 15 months of being in the middle of COVID to find out really what's working and what might not stay long-term versus what will. And I'm really looking forward to the back and forth exchange, especially with a payer in the audience. We'd love to have at least one insurance company or payer in the audience so that the provider side has someone to blame for anything that's not going wrong. Divya has volunteered and said she'll take all blame for anything that Sarah and Lee would like to throw at her. So we're going to have fun.
And the kudos too.
Yeah, absolutely. So with that, I'd like Divya, please do introduce yourself real quick, and then we'll jump to Sarah and then to Lee, and then I'll kick off with the first question.
All right. Hi, everyone. My name is Tita Paliwal. I serve as the Chief Clinical Transformation Officer at Horizon Blue Cross Blue Shield of New Jersey. And in my role, I oversee our healthcare value strategy as well as its execution with our provider partners.
Awesome. And for those of you that don't know, Horizons is one of those really advanced payer organizations. So they're doing a lot of really neat things, and they've been doing, the digital and the hybrid world for many, many years already. So they've been able to look at what the new world order of the last 15 months has given and really compare it and contrast it with what they had already been doing. Whereas a lot of other payers really, it was new to them. All of this was new to them. So they don't know what the pre-COVID digital world looks like versus the post. But I think Divya is going to have some good advice there. Sarah, please tell us about yourself and where you're from.
Thank you, and glad to be here today. I'm with Providence. Providence is a large integrated delivery network in the Western United States. We span several states from Alaska all the way through California, Texas, New Mexico, and many states in between. I'm part of the Digital Innovation Group, which is a group of approximately 200 folks across strategy, product development, marketing, digital experience, and venture. We make, we're really focused on transforming the consumer and patient front end of the organization and transitioning from largely episodic, offline, friction-filled relationships or non-relationships to engaged online, seamless, sort of between episodes of care relationships with our patients and our consumers. And really excited to be here today.
No, and it's also always great to have you back, Sarah, because Providence is one of those organizations that really puts its money where its mouth is and actually executes on these innovations, including starting companies up or actually moving these innovations into your hospitals and health systems daily practice, which is very difficult to pull off. Is, a lot of people do innovation on the side, but actually bringing it in on operational execution, that's where you're a specialist. So great to have you here. Lee, can we get you get to introduce yourself?
Yeah, thanks so much. It's a pleasure to be here. My name is Dr. Lee Schwam. I'm originally a stroke neurologist by training and still in clinical practice. I run a center for telehealth at the Massachusetts General Hospital, and I'm the vice president for virtual care at the Mass General Brigham Health System. We used to be called Partners Healthcare. We rebranded recently, and we're a major AMC-based network that also has about 10 other community hospitals and related outpatient practices. So we're a smaller integrated delivery network over 2 states compared to Sarah's 6 or 8 state conglomerate. But we do have some unique and interesting challenges as they relate to our very large academic research mission, our basic and clinical sciences. And so our digital health structure runs our electronic health record, but also encompasses all of the work that I do around virtual care. So synchronous and asynchronous care delivery, virtual urgent care, online second opinions, remote patient monitoring. So really trying to restructure our ecosystem in what is much more of a fee-for-service focused organization, which is looking to move more to a balance between fee-for-service and value-based care.
Yeah, that's terrific. And of course, Lee is being a bit modest in 2 ways. One is partners. A lot of people do know, started the movement quite a number of years ago with Dr. Kavidar and the connected health side. And of course, Lee himself has been one of the pioneers of telestroke. So you guys have been doing this for a little while. And maybe with that, I'd just love for you to start off, given how long, especially partners has been doing this and you personally, how has the approach to hybrid healthcare changed in your role, especially given you guys have been doing this for a long time? Did much change over the last 15 or so months that's going to stick around for a while?
Yeah, in some ways it's night and day. In other ways, there are some fundamental lessons that don't change. I think we used to be, an inch wide and a mile deep, and now we're like a mile wide and maybe 100 feet deep, right? We had a small group of providers doing acute care, hospital-based, sort of neuro-hospitalist care at 20 to 30 New England hospitals. So we became the de facto neurology service for all of the community hospitals in our network and in the surrounding area that just didn't have the resources and the volume to justify having their own full-time acute stroke teams. So we learned a lot there about the user experience, both the patient and the referring provider side, about the need for really robust platforms. You can't fail. It's one thing to reboot your computer when you're watching a Netflix movie. It's another thing to do it in the middle of an acute care engagement. So we learned our lessons there, I would say, but we didn't really know a lot about broad provider adoption. And in my role at the MGH, we had been getting people on board with the idea of doing virtual visits, something that everybody does now. We had been getting people on board with that for the last 4 or 5 years. We did like 10,000 visits a year. We were proud of doing 10,000 visits a year. And many providers were just simply not interested in even hearing about it. It's not for me. I'm a surgeon, can't be done. I'm a this, it's not relevant. Maybe it's for you, not for me. And then, in the matter of, I feel like it was like Fast and Furious, suddenly the car was going in reverse at 60 miles an hour and the wrong way on the highway. And now people were banging my door down saying, you have to get me on this platform. I can't function a day without it. So I think the biggest thing we learned was that all of our preconceived ideas were largely erroneous. What people thought this would do and how people thought people would engage and whether they thought old people could or couldn't do it or young people would or wouldn't do it. I think we're just learning. We had a lot of preconceived ideas. A lot of people, I think, got in trouble building programs around preconceived ideas. So we really tried to let the reins go and let the market pull us along and just keep rushing to build support, documentation, and compliance like behind the wave rather than in front of the wave. And created lots of new relationships. I mean, I didn't really know Sarah a year ago. And now we talk almost every month because it's just a different world and you need different colleagues. And there's been a tremendous amount of collaboration that COVID enabled, that competition would never have permitted before. But in this all-out war to just keep everybody alive, we saw intense collaboration that for me has been one of the most rewarding things about this.
That's fantastic. And Sarah, I'd love for you to comment on what Lee said, but maybe expanding that to what are the differences that you're seeing, especially for the things that the innovation shop has learned so fast that it can now apply taking forward. And Divya, as you're listening to both Sarah and Lee, what I'd love to get your comment on right after Sarah talks to us is, what are some of the best things that you've seen across providers? Because you do have the longitudinal view across the providers. So we'll have you comment on that in a second. But Sarah, take it over.
I wanted to hone in on a couple things that actually both you and Lee said. One was around just the nature of partnership, and the nature of partnership both internally and externally. So I think, health systems have exhibited a level of partnership that we've all maybe thought about or dreamed about in the past and just haven't been able to execute on. And to Lee's point, we built on each other's work tremendously. So rather than every single health system having to recreate the wheel, which we're famous for, we actually leveraged each other's work in the very early days. We worked really closely with MGB actually in the early days around chatbot, around symptom checking, around triage, around remote patient monitoring and COVID monitoring programs. So we shared notes, and that's one of the ways by which health systems were able to get, things like chatbots, which have been viewed with some degree of skepticism, up and running in a matter of like 3 days, or a COVID monitoring program up and running in a matter of 4 days. So which was the case for Providence. So I would say that's like from an external partnership standpoint. From an internal partnership standpoint, Shahid, you actually referenced, innovation is often somewhere off to the side, innovating around the edges, or, moving fast and doing things in a nimble fashion, and where, and they do that intentionally. What we actually learned was that we kind of busted the myth around like working. The closer you work with the health system, you can actually move faster if the nature of the partnership changes. So, we were, at least in the early days of COVID, doing like multiple per day stand-ups, clinical plus product development, for instance, teams, co-designing, building algorithms together. We did that in our COVID monitoring program as well, where we started talking between clinical and a partner company, as well as the digital team, on a Friday, and by Tuesday we launched our program. So it was really just like that really close synergy. And then I think we've learned, Lee referenced a couple things. We've learned a lot about like actually incorporating and doing true digital enablement in the context of a health system. So separate from the partnership point, but really like, what are the key drivers for why we do technology and why we do digital enablement? I'll give you one example, which is like a lot of folks talk about just making the visits available will drive adoption, or like we thought that might be the case. And of course, we knew prior to COVID that was simply not the case, because everybody had telehealth capability, and pretty much, we all sucked at driving adoption. And we've learned a lot of lessons around how telehealth is actually driving inefficiency among nurse practice, and how it creates a lot more work for them. All these workarounds that exist for the care teams as well as for patients. And so like we've started to learn, like, what do we need to do next to make this actually possible in an operational environment, workflow related changes, payment related changes, which I'm sure we'll get to. And then finally, sort of this notion of like not thinking about the different components of the business separately. You don't have virtual care and then you have physical care. It's all care. And it's mostly about aligning that care to what the patients are looking for, what their intent and motivation is, what their behavior is, and getting them to the right care for their clinical and non-clinical needs. And doing so in a way that also works for the system delivering the care. And when I say system, I'm not saying health system necessarily, just whatever the underlying system is that delivers that care. So we learned a lot of lessons there, and then how we do longer term transformation around the things that Lee described, like what's appropriate to do telehealth, to apply telehealth to, both at a point in time as well as longitudinally, which I can talk about a little bit more. But I know that was a pretty broad answer, but I think
that's exactly the way we want to
so much of our, what we do.
Perfect. So Divya, could you give us a little bit of understanding of what is the best that you're seeing in hybrid healthcare that's occurring maybe across some of the organizations that you're seeing as providers within your network, especially from the payer angle, but you're going to see this wider. And as Divya is talking about that, I'd love for Lee and Sarah to think about what are some of the mistakes that the health systems are making, where if they worked more closely with their payer partners, that maybe some of those mistakes would go away. So Divya, will have you start, and then maybe Sarah and Lee will comment on how a better partnership with payers may improve there. Sorry, Divya, go ahead.
Sure. So first, I just want to echo what both Sarah and Lee talked about in terms of just the pace of innovation and collaboration that we saw, particularly over the last year. I mean, it's no surprise to anyone, just the skyrocketing of the number of visits that we saw with telehealth. In our own claims data, what we saw is, if you do a comparison between December 2019 to April 2020, which was the peak of when we saw these telehealth visits, there was almost a 1,400% increase, right? It's obviously matured since then. So the December 2020 numbers or the February, April numbers this year are lower than that. But the bottom line is the telehealth is here to stay. And I agree with what Sarah said. What we now need to do is not think about it as a separate product or just a channel that can be availed if the traditional channel cannot be sought for. It needs to be a part of an ecosystem, right? How do you build that, and how do you embed it as part of the workflow, as part of the operating system of a healthcare organization? And so what we saw, in April, I still remember over a weekend, we came together with our provider partners and we said our members were seeing, multiple hours, even days worth of wait time to get onto one of these channels, a traditional, virtual visit. And at the other end, our provider partners were hurting because they weren't seeing the usual volume. And we had to construct within the span of a weekend, and we designed and incubated, standing up what a virtual system would look like, and implementing it so that our members could seek care. Since then, what we have seen is there are a few areas where, in particular, there has been a big value delivered. Behavioral health is one of those. In the past, what we saw was just in the traditional brick and mortar setting, there wasn't a strong glue. There were high no-show rates, and just the adoption and members being engaged in their care was such a big challenge. Telehealth in behavioral health is one of those areas where we've seen a lot of traction, and members being able to access care, not necessarily having the stigma that some feel in the traditional setting. So that's one area where we have seen a lot of uptake, and hopefully that will continue to stay in the future. Geriatric care, that's again, how do you take care of the frail and of the elderly and vulnerable people, and bring care to them? It can be at home or it can be near home, but how do you set up care so that they can be monitored effectively? And we have seen ways in which it has worked very well. So one of our independent primary care practices, what they launched recently was a medical assistant program. So a medical assistant would go into the home of their patients, of their highest risk patients, and actually enable a high video quality visit, right? Instead of having the patient or the member or their caregivers try to somehow, work all of that out. So I think it's being able to utilize technology along with the empathy and recognizing that, different patients, members, consumers, whatever you want to call them, right, they are in different parts of their journey. and how do we meet them where they are to help solve for their pain points, for their challenges. And then lastly, hospital at home, the concept has been around for a couple of decades. Lee talked about telestroke in terms of system to system, but when we talk about hospital at home, now we are starting to hear our health system partners talk about that, whether it is a CHF or COPD or community acquired pneumonia, how can we look at that hospital stay moving over to the home? So those are some of the areas where we are seeing the most innovation.
Awesome. So why don't you add just a little bit more, Divya, for what are some of the techniques or things that maybe you think providers should be doing to work better with payers? And then we'll let our provider audiences, our provider panelists tell us what they would wish payers could be improving, and not necessarily for Horizon, and not necessarily for, obviously none of you I think are in the same market, so you can talk about it more generically. But I love this idea of the ecosystem, but often when we say ecosystem from the health systems, they feel that that's the health systems ecosystem. When we talk about the payers, I spent 4 years at AHIP as a entrepreneur in residence, and so we know that there's not a whole lot of real innovation collaboration going on with providers in most parts of the country between payers. So tell us a little bit about how that can improve, and then we'll have Leah and Sarah jump in as well.
Sure. I mean, I see the traditional lines blurring, and they'll continue to blur more. And I mean, we've got to collaborate and we've got to partner. At Horizon, we've been working with our provider partners, particularly the value-based partners, where my focus is, along the journey of how do we continue to help support the care delivery innovation, whether that is through helping bring transformation education, whether that is through bringing in collaboration or new partnerships or reimbursement evolution. So a couple of examples related to that on the reimbursement piece. One of the findings of last year was fee for service is a challenge, right? And the challenge that our provider partners felt, particularly last year, was when the visits reduced, right? There was a dramatic drop in the fee-for-service revenues. And so we had a lot of our primary care practices come to us and express a re-engagement or renewed interest in terms of looking at global payment models. And so we have worked over the course of the last few months, and we are going to launch in July 1st of this year, our advanced primary care model, which essentially combines fee-for-service and value-based and gives one lump sum payment on a monthly basis to these provider partners. And they get to choose where they want to spend the most time in terms of, and how they want to spend that time with their patients, right? So those are the kinds of innovation that we want to advance and help embrace. The other area, Sarah talked about episodes, pregnancy. How can we use advances in remote patient monitoring, remote fetal monitoring to help advance some of the care needed during the pregnancy episode. So incorporating those elements within the reimbursement model that we set up for these episodes is another example. But I think it's examples like those. It's integrating behavioral health. It's integrating care needed to dissolve social determinants, structural barriers, right? Those are the elements that we work very, very strongly with our partners on.
Perfect. Yeah. So Lee, I'd love for you to comment on this one point, and that is there any long-term innovation possible if we don't innovate the reimbursement, payments, et cetera model? And if we don't innovate there, how long do some of the innovations that we've brought out in the last year and a half really last? Could they last?
No, it's what a stimulating conversation. I mean, if I had my own microphone, I would have been commenting every 3 seconds on both Divya and Sarah's comments. Let me say a couple of things. I think one of the most valuable lessons that COVID taught us was the power of this sort of hands-off, sleeves rolled up kind of collaboration, right? So hospital systems just shared openly their intellectual property with each other to help combat this wave of admissions and overwhelming volumes. Payers stepped up and said, no copays, no cost sharing, right? Like, hey, we understand it's a crisis. People need access. So we had unfettered access, and we did not see what everyone has been so worried about, this rampant overuse. We didn't see volumes that quadrupled. We may have seen a quadrupling of virtual volumes, but our in-person volumes were, 25% of what they'd been. We did 1.7 million visits from March to the end of the fiscal year in October 1. We never crested above our expected volume. It was all just filling back in the access that was missing. And you could argue we probably had more demand for healthcare during COVID than less demand, different kind of demand, but total demand should have been high. So that should be a lesson, that the fears about fraud and abuse, which are largely unfounded, and the fact that you can make access easier without just uncapping, the barrel of gold coins. So I think that's really important. I think the second thing is we don't just need reimbursement reform. We need kind of like platform reform. We can't have, much as I love the ecosystem and the sort of operating system metaphors that Divya used, we can't have Blue Cross Blue Shield of Massachusetts saying, oh, you can use the platform, but it's our platform. And then United saying, you can use the platform, but it's our platform. Right? We need to be able to treat this just like any other form of healthcare. The health system has a delivery module. The health system does virtual or in person or a combination, whatever is driven by the clinical appropriateness and driving to the lowest cost setting. Hospital at home is a great example. If we can lower cost of care and improve patient engagement and safety and satisfaction by shifting the hospitalization to home, that's the way in which I think we really have to collaborate. What I think is the unspoken truth is it's not just who pays for the visit, who pays the annuity of the increased cost of the new workflow, the new technology, the new platform, because everyone is saying, oh, virtual is cheap. It's cheaper than in person. So now we can pay you 60 cents on the dollar, or we can project your costs going down. Costs are not going to go down until we really get to massive and sustained scale, and we don't have to build any more new buildings. We can actually start repurposing our existing buildings. And then the last thing I would say is, Sarah said, don't reinvent the wheel. I would say, rent the wheel, right? Like if Sarah made the wheel and it works really well, let me just rent it. I don't have to buy it and build it and recreate it. So I think we have to get smarter about creating modular, consumable components. And Sarah and I have been working a lot on this idea of a kind of nonprofit, hospital-driven national network concept where we can be puzzle pieces that all click together to be able to offer national products for insurers, for employers, and trade with each other in a way that enables everyone. It's like interstate trade, right? Or intercountry trade. Trade is good for everybody. It's not just good for one party, it's good for both parties. So those are my thoughts.
No, that's perfect. And maybe, Sarah, as you start your comments about how payers and providers can work better together, maybe mention a little bit about Truveta as another example for what Lee was referring to, which is health systems can get together and offer something to the public that everyone can use, payers, providers, manufacturers, et cetera. So just mention that for a couple of seconds, and then we'll take your comments.
Yeah, sure. I'll actually start somewhere else and then I'll get to Truveta, which is that the question that you asked was, is innovation possible without collaboration between payers and providers and a rethinking of the financing mechanism of healthcare? I would say, sure, but it's not going to look like what we want it to look like because there are a lot of digital disruptors out there who would, under normal circumstances, have paid, a lot of money to have the kind of education and market disruption that occurred on their behalf, done by COVID, over the last year, and they don't have to do that hard work, right? To educate people, to drive adoption. It's there, the market's ready. And these disruptors, you know, they're digital first. So they're lower cost. They can automate and deliver much more scalably. They have, they can utilize data and analytics to generate insights in a way that we cannot, or that we have much more difficulty doing for a number of reasons. They do not own the full care experience. They target the profitable services, so they can spearfish and kind of go after what works for them and where they can make money. So they target those. They don't have to adhere to traditional payment mechanisms, fee for service, or they don't even have to engage in the same type of value-based kind of conversations that we do, right? So they've got degrees of freedom around and business model innovation that we have much more difficulty doing. So I would say, like, and there are a whole other list of things that we could talk about here, but that's not the focus of this panel. So I would say, yes, absolutely. Innovation will continue to occur. It's a matter of how much is it going to cost traditional players, and are we going to be around in the long run? Like, what's going to happen to our ability to care for our communities in a holistic way that's not fragmented, if they do. So that's what I would just say, because I think it's just like, we tend to think so narrowly about just healthcare, and, you know, how what we do is so complicated, and it is. But we are not impervious to outside disruption. So I just wanted to say that. As part of that, I'll give it. So you asked about Truveta. You know, coming together as health systems to combat some of that disruption is really important. Like, Providence's data unto itself is interesting, but we can't really move the market, right, in any meaningful way with just our own data. Same with NGB. They can do some, but they can't meaningfully change the market and create new ways of looking at data, new ways of analyzing data, new ways of using data to drive research or clinical practice, or any of those things, like, on their own at scale. We would all struggle. And so with that premise in mind, Providence and several other health systems came together across the entire country to create a data consortium, which is Truveta, and it'll create sort of the data infrastructure for beginning to build additional things on top of it. And it takes that notion of partnership into sort of the next level in terms of being able to, for systems to work together on specific use cases. So so that's one of the ways by which we can combat disruption, I would say, in a way. And also, you know, we are all much more capital constrained, whether we're payers or providers, with some rare exceptions. We're all much more capital constrained than, like, say, the, you know, Amazons of the world. And so these types of partnerships and consortia are one way by which we can actually sort of compete on the same playing field.
Yeah, that's great. And so we're going to open it up now for questions, but just a quick, there's an example, I think it's called Civica, which hospitals and health systems got together and said, hey, we use antibiotics all the time. Maybe we should make our own, quote, generics, right? So I love this idea of the health systems actually taking advice as well as patterns from the outside, because if you don't disrupt yourself, I mean, you mentioned Amazon, you know, one of the most famous things that they do internally is disrupt themselves before someone else does it, right? I mean, that's what Kindle was. That's what a lot of the other innovations that they're coming up with. So I think that part there makes a ton of sense. So with that, I'd like to, you know, thank Sarah, Divya, and Lee. We're going to open it up for questions now. And if you have any questions, please ask. If not, of course, we'll continue with the audience here, with the panelists here, and you can ask your questions in the chat. Okay, that's great. So as we get our panelists up on the platform here, we've got two really good questions and a bunch of other discussions that were going on. And if either Nick or Neil would like to come online to ask the questions, that would be great. Otherwise, I will go ahead and at least present Nick's question. Because it's a little bit easier. I'll let Neil join us online if he's able to ask there. So Nick's question is, with more and more patients having heightened awareness of their care plan and focusing on healthcare costs, facilities are posting their charge masters digitally out to their public websites. So Lee, I think you can hear the question. Divya, I believe you're hearing the question as well. How do you see the CMS price transparency rule that started being enforced on January 1st affecting patient and insurer payments moving forward? Do you expect more collaboration between facilities and payers, or do you expect more competition between facilities and payers as was expected from the rule?
Well, can you hear me okay?
Yep.
I think this is a testable hypothesis, and there are so many different factors at play here that it's going to be hard to sort out exactly what the drivers are. But I will say this: it was an article in the Wall Street Journal not too long ago pointing out that price transparency isn't so transparent after all. First of all, a lot of places really didn't put the data in a manner that's readily consumable. But I would argue even, we're not buying groceries in the grocery store. You can't tell somebody what the cost of their evaluation is going to be. You can give some prices for standard packaged services. You can say, what a typical maternity delivery, admission will cost, that kind of thing. But I don't think that most of our patients are price sensitive to the degree that the modest or even larger differences in cost, they don't really matter, because for many patients, they have an out-of-pocket maximum, they have for cost sharing, and they have a copay, and that's what they're going to see. So once you get over that, $14,000 for the surgery or $22,000 for the surgery, unless someone is private pay or has a plan where they just have to pay 20% of full cost no matter what it is, they're not actually going to be sensitive to that price. So I think patients may be more likely to shop around for urgent care and digital primary care and opt for more price-sensitive services there. Amazon offers an enhanced Prime membership or a one-click get a response. I think we could see a shift into that. But for patients seeking the kinds of services for which the price transparency is theoretically going to be helpful, I honestly think it's going to be more relevant for employers and insurers, and it's going to have an impact on contract negotiations. But I'd love to hear what my colleagues think.
Sure. And Sarah, were you able to hear the question? I think you were joining at that time, so you heard it. Great. We'll let Divya go first in the middle as far as payers are concerned. What are you seeing, Divya, with respect to price transparency? Do you feel it's going to be more or less competition between the two sides? And then, Sarah, you can jump in as well. Divya? And Divya, you're on mute. We just need to press that microphone button in the top.
All right, can you hear me?
Yep, go for it.
Yeah, okay. Yeah, I agree with the comment Lee made about the price sensitivity and the way that healthcare consumers, members, patients, the way they behave and take price into consideration in terms of making decisions does not necessarily mirror how we look at any of the other areas of our lives and make decisions accordingly, right? So it still needs to be seen what kind of a role that will play. Clearly, I mean, I think in terms of there are certain areas where it makes a lot of sense, and just having that transparency is a step in the right direction. But again, how that information gets consumed, because each healthcare organization can make their own determination of which prices they choose to be transparent with. So we'll have to see that work. In terms of the original question on will it bring more collaboration, I think getting to a collaboration takes a lot more. It's a lot of different things that come into play, and it's every single thing that we do together as partners and as organizations together that comes into play. I don't think one single aspect, getting price transparency, necessarily will moves the dial. It's a lot of different things that we do together.
Got it. So Sarah, you can comment on this, and then we'll bring up Neil's question as well around the investment side. So any comments on what is pricing transparency, good, bad, indifferent, just like Lee and Divya talked about?
I'll just quickly say, I think Lee and Divya hit the right note, which is that it depends on the service. But I will take a slightly different approach and say that I think ultimately, if it's for the types of services that have the attributes of being shoppable. So urgent care is what Lee referenced. I think there's a lot of primary care that falls in this category. There's a lot of specialty types of care. Dermatology is an often cited example. I think the impact of this will be seen when the market moves in such a way that, for instance, Walmart starts to see a lot of traction around its primary care and its $25 primary care visits. And through this price transparency work, patients are going to look and say, hey, why does this say $500 for me? And I think then the market's going to shift, and it'll influence the way by which we as systems price things. Now, I mean, there's all the details around whether the charge master is like even a useful tool or not. So we don't need to go into like sort of the tactical details. But the fact is that for certain services, the market will dictate what it will bear as opposed to what we want them to pay. And I think that's where this becomes kind of important. And like from a digital perspective, there are very different opinions about payment parity, for instance. And there are folks that say we absolutely need to be reimbursed at parity for telehealth visits to the equivalent visit in a physical setting. Well, is that the right approach? Probably not. Again, as Walmart and Amazon Care and all these other offerings get traction. So I think it depends on the service, and I do think it'll move the market. It's a matter of time.
Yeah, I just think just to jump on what Sarah said, hearing aids. Certain kinds of procedures or consumption that's generally not covered by insurance for many Americans. Dental care, we didn't even talk about. I think, if you see a $15 hearing aid at Walmart and a $2,000 hearing aid at the doctor's office or the clinic, and $2,000 is cheap for a hearing aid, by the way. I think that's where price transparency, I think, is really going to make a difference. And I agree that it's like the sign in the back of your hotel room. Ever read what the rates are in the hotel room? A studio hotel room costs $2,000 because no one pays that rate. Our charge masters have a little bit of that feeling about them as well.
No, that's fair. So Neil, we've only got a couple of minutes before we have to move to our next session. Do you want to quickly ask your question? And you're on mute at the moment. Just in the top left.
Okay, yep. Am I off? Okay, yep. Sorry guys. Appreciate that. So, I got a foot in like 3 camps here, and you all have addressed a couple of them and done a nice job. But you got the value hypothesis team, the Oak Streets of the world, tons of money going to that. You got tons of money obviously going to telemedicine, right? It gets to Lee, yours points about a sort of a new workflow and new capability. But then there's lots of people who are still building hospitals, still building new physical ambulatory clinics, still signing new leases. And I don't see how all those 3 things can be true at the same time, at least going forward at some point, right? And I was wondering what the thoughts were on sort of who's going to eventually get sort of squeezed out.
Well, I think if you, I just want to, tee off of what Sarah said before. The cost of a new visit, telehealth or in person, when you look at the composition of the fee, which is provider time, not different, malpractice coverage, not different, practice expense. I mean, malpractice might be higher, but practice expense, heats and light and electricity, okay, those you save. But quite frankly, the MA, the scheduler, they still have to do the work. They just do it differently. So that's not where you save money. Where you save money is an incremental visit cost. So when I have a clinic of brick and mortar and it's full, my next visit does not cost me a new building, doesn't cost me a new incremental investment in brick and mortar. So I think the answer is we'll see expansion and contraction across the country as patients if they're given the true freedom of choice, pick where they want to be seen. And if they move away from brick and mortar in their neighborhood, like their bookstore, and they move online for virtual from other vendors, then you'll have spare capacity in some places. And these other groups, either new ventures, the 98.6s of the world, or established health delivery systems, won't have to keep building new buildings to keep pace with demand. I think that's where you'll see the big savings.
Yeah, perfect answer. So unfortunately, we're out of time. And Neil always asks great questions, but we couldn't finish all of it. He is a speaker on our panels as well, so we'll get him on one of our future episodes too. So with that, I wanted to thank Sarah, Divya, Lee for joining us here. We're going to go to our 2:45 session now. So we'll see you over there. Thanks all. Bye.